Welcome to Practice Pearls, Overcoming Therapeutic Inertia. Today, we're going to discuss some tips on overcoming resistance to treatment intensification. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. Joining us today is Dr. Andrew Bzowychkyj, who is a PharmD and Associate Professor of Pharmacy at Pacific University in Oregon. I can tell you, thoroughly impressed with Andrew, as he is a runner who has a personal goal of completing a marathon in every state in the country, and he's already done that in 11 states. Not only that, he's recording today from a standing desk. Welcome, Andrew.
Thank you so much. Very happy to be here.
Just to level set, therapeutic inertia is defined as the failure to advance or de-intensify therapy when a patient's therapeutic goals are not met. I understand, Andrew, that you've developed an approach that helps overcome resistance to therapeutic intensification that you call the multiple choice approach. Can you tell us a little bit about that?
Yeah, absolutely. So still working on the name, but the concept's fairly simple. I think of it kind of like a multiple choice problem. And so when working with patients to try and figure out what best to do for them and working with them to determine the right steps to move forward, I generally offer patients three options. So one of them is no changes to medications. As a pharmacist, normally my role is looking at medication adjustments. So I'll offer that option as a patient. You know, we can always do nothing. But as part of that, I try to emphasize something has to change before the next appointment, because if we don't do something in terms of eating habits or exercise or physical activity, we're going to end up at the same point. So in this route, we really walk through SMART goals to encourage accountability and follow through. You know, the second option is normally like a minor change. So it might be like a slight increase in insulin dose, maybe an increase in a dose of a oral or a GLP-1 injectable, but something I would consider kind of minor. So we're making kind of small steps for patients that are maybe hesitant to make a huge step. And then the third one is something significant or substantial. So if we're thinking insulin, maybe 10 to 20% dose adjustment, or maybe we add a new medication. And so for patients, that can be quite a huge step. And so we kind of lay out, these are our three different options, and we walk through each one, you know, and making sure the patient's comfortable with whichever one they think kind of fits most in line. And I just want to emphasize it's always in the context of maximizing lifestyle modifications. So emphasizing to patients, we can't just rely on the medications to do all the work. We need to kind of balance the three elements together.
That's interesting. Andrew, what do you do when a patient picks the choice where they're not making any change?
So yeah, it seems like that would run counter to the whole idea of overcoming inertia. So if there's no change to the medications, you know, that opens up a really good discussion with the patient about, you know, if we don't change something, we're going to end up back at the same point that we're at right now. So 4 weeks from now or 6 weeks from now, whenever our next appointment is, you know, having the patient really walk me through what is it they think they can do differently in terms of maximizing lifestyle modifications, or remembering better to take their current medications, whatever it might be. I'm really trying to emphasize basically what's that different piece going to be, so we don't come up in the same exact point next time.
It's critically important. And that approach reminds me a lot of motivational interviewing, where we know there's a wealth of evidence that says when you give people choices, it creates more buy-in. When you tell people what they're supposed to do, there's often creation of resistance. So is this taken from that motivational interviewing literature and then reapplied in a way to our care of patients with diabetes?
Absolutely. I think taken sounds like a bad word. So I'm borrowing or using and applying, but absolutely, this is rooted in that concept of motivational interviewing, just helping the patient walk through their different options and make sure they're picking the one that works best for them.
It sounds like a wonderful approach. How do you talk through options then in the context of a patient's lifestyle, preferences, cost concerns, that sort of thing?
Yeah, absolutely. So I think there's a bit of homework to do beforehand. So walking into each appointment, I try to have my available options already. I think it's important that we don't make the decision of this is what's going to happen today, but knowing what's available, especially looking at like the insurance formulary of what's covered or what's preferred for a patient. So we can really get down to the specific drug name. When discussing kind of the different meds to add or adjust, I always discuss how does that play in with, as I mentioned earlier, exercise and meal planning. And then I also ask about any financial concerns or implications. If we added a new medication, what if the copay were this? How would that affect you? What about this? And then lastly, I think it's important to go through the pharmacology of each of the drugs in a patient-friendly language. So if the patient knows how it works and how it's kind of interplaying with their other aspects of their life and their diabetes, I think it can be more effective than kind of popping a pill and walking, going about your day.
Andrew, it's interesting. As I listen to you speak, I hear you incorporating some of the suggestions from another of our Practice Pearls video, where we talked about respect for patients, patient-friendly language, non-judgmental approaches, and meeting a patient where they are at about the things that they are interested in, which was all what you described. What comes after you've had these conversations and then treatment changes are made?
So a couple ways to think about it. If there's been no change, part of that inertia piece is you never really make any movement. So to avoid that, I, in the medical record, document our discussion. I document the patient's concerns and what their commitment was to change, by the next appointment. I also put it in the after visit summary. So the patient has that in writing. They know what we're talking about. I know what we're talking about. And it really helps focus on transparency and realistic goal setting. And then at the next visit, it gives us a really clear starting point. This is what our plan was. How did it go? And again, in a non-judgmental way, people aren't always able to do everything that they want to do. And so always trying to support the patient. Is a medication change, or if there was some sort of hesitancy, I picked up the patient, I don't know, was maybe a little bit concerned. I do what I call it, the namings aren't that great, but like a 3-day phone call or like a patient message in the EMR. Mainly, did they pick up the drugs? Were there concerns with the pharmacy? Oftentimes the price, there's some sticker shock. A medication might be out of stock. The patient may be hesitant to take that first dose. And so that 3-day phone call still kind of captures that energy we had from the visit to make sure that we're still able to kind of follow through with the plan and then adjust if we have to.
It's interesting that you use the term energy because inertia implies a lack of energy. And one of the things that you create by active engagement and choices and then follow-up is energy to move forward. What else do you encourage your patients to do, and how does that empower them?
So we've really kind of gone through a lot of the basics. I think the other piece is trying to make it a habit to talk about what the next line agent might be, especially in a situation where we're not making any changes. A couple things, I think it helps the patient realize there's more options. So I think sometimes patients, especially once you start going through the whole list of medications, they wonder, what else is available? Am I, going to run out of options? And so there's always more options available. It also helps the patient research the medication. So I'll write down the specific name or the drug class of what I'm thinking about. And I encourage them to Google it or watch out for TV commercials. They're all over the air. And so it's really the patient seeing this. And so we may never add it, but talking about it really helps them do some research, because honestly, I would rather them do that research and come back to ask me. It kind of opens up and encourages that discussion rather than kind of going to a website, getting that information and relying on that as their sole source of info. So kind of inviting those questions, inviting those concerns, as opposed to kind of hiding from them.
That's a great point. It really opens up that conversation, which in turn facilitates trust, which in turn facilitates adherence. If there was a take-home message for everyone, what do you think the most important take-home message is about the approach you described?
So I think one of the biggest things we've emphasized is giving patients options to choose from can make it a lot more human for the patient. So you're showing them your thought process as the clinician, you're including them as part of that decision, and you're really keeping it focused to avoid overwhelming. And so that's where like those 3 options really help to really give the patient options, but not make it so overwhelming that it feels like nothing can be done. I think that's really critical.
That's a great point. So to sum up, by giving people a range of options, some might be easy, medium, more difficult, it meets a person where they are at and allows them to make a choice that's most consistent with both the energy they have and their values, and it also facilitates trust and an opening of conversation that helps them to move ahead. And by moving ahead, hopefully leaving behind some of the therapeutic inertia that we're all often subject to. Andrew, this really was a fantastic approach and a fantastic overview. For our audience, for more on overcoming therapeutic inertia, just go to therapeutikinertia.diabetes.org. For the American Diabetes Association, Andrew, thank you very much.
Thank you.
I'm Dr. Neil Skolnik. Thank you all for joining us.